Hi, and welcome to the podcast. Today, I'm joined by Megan Roberts, PhD and SLP. She is the principal investigator of the EI Research Group at Northwestern University. And today, we are going to be talking about family-centered early communication interventions for young children with language delays. So today, we're going to describe the importance of caregiver coaching in early intervention, discuss the importance of talking with families about ASD, describe different methods of ASD assessment, and describe ways to incorporate data and science into our practice. So welcome, Megan.
Thank you so much for having me. I'm really looking forward to talking about all these things that that really matter to me and I love talking about.
I'm so excited. Thanks. Oh, go ahead.
No,
I just wanted you to introduce yourself and tell the listeners a bit about how you kind of got into the field of becoming an SLP and then a researcher.
Absolutely. So my undergrad degree is in economics. I was a double major in Spanish. I really thought I was going to work for like the State Department. And my mom was a pediatric physical therapist. And of course, I'm like, ew, I don't want to be like my mom. And then I'm just literally exactly like my mom. I realized after working, I think I worked for like some financial company as an internship, and I was like, ooh, that's terrible. And I always loved kids, and I really loved language. And I was like, okay, so maybe I'll do speech pathology. And so, of course, I had none of the prerequisites. And so I applied to these programs. It was like, hey, maybe you want to take me, even though I know nothing about really any of the prereqs. And so Emerson College at the time had this really innovative like summer program where I could go and do all the prerequisites and then get my degree. And I did that. And then I worked in early intervention and at an inclusive preschool in upstate New York for a few years. And then I decided I wanted a little bit more. And so I got my PhD at Vanderbilt University, actually in special education, which is, I talk about this, a lot of the intervention work doesn't happen in speech pathology. I'm not exactly sure why that is. It more happens in special ed. And so I did my PhD under the mentorship of Dr. Ann Kaiser, who is one of the most leading experts, amazing scientist in parent-mediated intervention. And so did my PhD there. And then in 2013, took a faculty position here at Northwestern, where I've just been able to expand my science, but also, keep I'll talk about this in a little bit, but keep up my current like clinical practice. So I serve on an autism diagnostic team, which has really informed a lot of my science.
That's awesome. And, I know we talked about this before, but we have that Northwestern connection because I went there for undergrad and grad and worked at a research lab in the psychology department there. But that's how I got my start in speech pathology, because I was a psychology undergrad. And then I worked for a language learning lab, and it just was so fascinating and interesting. And it's really cool to kind of see behind the scenes at a research lab. And then I know you have an Instagram account, which I think is so helpful for clinicians and parents. And can you tell a bit about your Instagram account?
Yes. So I wish I could take credit for that. There's a reason you surround yourself by awesome people. So I have an amazing lab, and they were like, yo, Meg, you really need to get on social media. And I'm a massive introvert. So I never had Facebook. I mean, I think I have it now, and I think I have like literally 2 friends. I think one's my mom. And so I didn't grow up, I just never used it. And it was very clear that that's where SLPs live, right? Is on Instagram. Mm-hmm. Maybe TikTok now, if I know correctly, but maybe I'll do TikTok someday. But the whole purpose of research, I think, in good science is actually to change things in the wild in real life. And so if you don't go to the places where people are gonna miss out on things. And so we are on Instagram. We try to summarize papers we've written. They don't make me. They suggest I write things about what it's like to be a mom. So you'll often see funny things like I pranked my children on April Fools, and I made Brussels sprout cake pops. Like there are silly things about me just being a mom, and then there is more serious things like the research that we're doing. But it all lives on Instagram.
So cool. Yeah, I definitely follow you. I think I saw recently you did, or a few weeks ago, you did like a day in the life of your life.
Yeah.
And I was so impressed because I think you get up at a crazy hour, like 4:30. Is that right?
I do. I go to bed really early though. I'm just a morning person. But
Yeah.
yes, I do.
Yeah. I'm trying to do that, but unfortunately it's been a bit I've been waking up early, but also going to bed late. So not the greatest combination. But okay, so before we get started, because this is going to also be offered for ASHA CEUs, I'm going to talk about my financial disclosures. So I receive payments from Tassel Learning, royalties from my 4 children's books on Amazon, payment from my course, Helping Your Child Communicate. And Megan, would you mind saying yours?
Yes, I am employed at Northwestern. They pay my salary, although nothing that I say they would reflects their opinions. They just pay my salary.
All right, great. Okay, so today, I know you're passionate about caregiver coaching, and you've done a lot of research on caregiver coaching. Can you tell us a bit about like what the research says about caregiver coaching?
Absolutely. So I think we know a lot and then not enough as well, which is a very unsatisfying answer. I would say 50,000-foot view, several meta-analyses, which is basically when you take lots of individual studies and you look at them together as a big body of work, which is like the highest form of evidence, pretty much says that involving the caregiver is great. It's good for child outcomes, right? So in our world, that might be social communication. It's good for parent outcomes in terms of things like self-efficacy. So how empowered or how confident do I feel as a parent to be able to do all the things with my kid? And family outcomes in terms of like burden and stress and being able to participate in all the things the family wants to participate in. And so in general, caregiver coaching works. What I think we need to know more about as a field is what specifically about caregiver coaching. And I think this is why, sadly, I think the estimates range from 10 to 25% of families actually get coached in real life. And historically, marginalized and minoritized families are even less likely to receive caregiver coaching.
Mm-hmm.
And so I'm really interested in, beyond just like, does caregiver coaching work at this point? I'm also really interested in like why it's not happening in real life, right? And, I think there's many reasons for that, but one of the big reasons is I don't think we operationalize or define what caregiver coaching is. And that's where I think we need more research, right? So like, what is it about engaging caregivers that is the secret sauce, for lack of a better word? Does that make sense?
Yeah. And when you say caregiver coaching, what do you mean by that?
Yeah, so I think that's the thing, right? Caregiver coaching can mean anything from sort of explaining, what you're doing to the parent while the parent watches you play with the kid, to what we might call guided practice with feedback, in which the caregiver is practicing with the child and you are coaching and you're providing feedback, right? And so sometimes we think of coaching as only that part of it, but it's really all of the things. And I would say that Julianne Woods and Molly Romano and all of these in that group that came from FSU, Florida State, have done such a good job of really defining and operationalizing what caregiver coaching really is. And so one of my PhD students, Jordan Lee, just looked at, so we ran a clinical trial, and in the clinical trial was not about what happens in what I call the wild, which is real life speech pathology, not research-based speech pathology. And we had a sample of, I think, around 20, 25 kids who we video recorded what happened with their community-based EI provider, in addition to what was happening in the study. And basically there was 0% of the sessions were spent with the parent interacting with the child and the EI provider giving them feedback. 0%. So now they were involved in other ways, like talking to the parent, but we know, like, you're going to learn golf or tennis. Like, it's not going to be me, like, oh, this is a tennis racket. Here's how I like serve. It's going to be actually practicing playing tennis. So that was that.
So what were these providers doing instead? Just kind of sitting and playing with the kids and having the parents watch, or having the parents not be there? What was happening?
It's a range of things. So sometimes the parents weren't there, or they were there, but they were like, doing other things in the house.
Mhm.
Sometimes they were there and watching, and the therapist might be kind of like explaining what they were doing with the child.
Mhm.
And then a lot of the time, I think it was close to 50% of the sessions were spent just playing with the kid and not interacting with the parent at all.
I see. Yeah, I mean, so I've been doing early intervention for 15 years now. And as a younger therapist, I have to admit, I was really intimidated to come in, young, obviously, and telling these parents how to play with their kids. It was very intimidating and how to, and I think that obviously, as I've grown as a clinician, I'm so much more comfortable now coaching parents and showing them how. And I think a lot of it, and I love what you do, is kind of giving um, clinicians strategies and ways they can coach and ways they can talk to parents. And can you tell a little bit more about some effective coaching strategies that you do in your research studies?
Absolutely. And I will say that when I was like, when I worked in early intervention, I brought in the toy bag. I did not coach the parent. Like,
Mhm.
this is not something I did until I really was more later in my career. And I think that's part of why, we're doing this podcast is to how do we support all clinicians, but particularly junior clinicians, in doing this scary thing, because they're thinking to themselves, dang, I'm not an expert. Like, how possibly could I coach somebody else to do something I'm not exactly sure I know what I'm doing,
Yeah.
right? Like, those beginning years. And so I would say my advice is different for like where you are in like your own development. So if you are a new clinician and you're listening, and you're just like, no way, Meg, not happening. I'm just trying to survive, like running around from house to house in my car and stopping at McDonald's to pee. Living the good EI life. I would say, don't teach them all the things. Teach them one thing that you feel really comfortable with. And if it were up to me, and I used to joke about this, I were queen of the world, I would teach every parent how to be responsive,
Yeah.
meaning like contingently responsive. So when the kid is pointing to his milk, and going, ah, ah, a lot of times parents will say milk, or you want the milk, which in the kid will shake his or her head, yes, right? But that's not teaching the kid what you would want them to say in the moment, right? And so what I would teach parents is like, imagine you're the kid. What would you want them to say in that moment? And you model that for the child. So when the kid's pointing at the milk and grunting at the milk, you might say, if this kid is 12 months old, milk, right? If this kid is, is already saying milk, right? You might say, I want the milk, and modeling what you would want the kid to say in that moment. And so I think that would be the strategy, right? Or if it's not even, that's an example of a request. But a lot of times kids might point to something, right? They might see something really cool, right? And they might point to the bird and be like, oh, and you might say bird. And I see that bird too. That
Mhm.
bird is flying. And so modeling, responding to what the child's interested in and focused on with something that is developmentally at or slightly above their level, to give them that rich linguistic input that's about what they're interested in.
Yeah, I think that is, oh, sorry, I cut you off. Go ahead.
No, you go.
I think that is great advice. And I love teaching parents those strategies. And they are kind of easy to teach because you can all do it together and, all sitting around watching the child play and just talking about how to focus, how to talk about what the child is attending to and how that is so beneficial for the child's development, because what they're attending to, that's what they're learning about and that's what they want to learn about. And actually, I was just in a session with a parent last week, and this child had a really cool toy. So I started to say, oh, look at this. Oh my goodness. And I was trying to show her what the toy was doing and get her to kind of like attend to the toy. And then I pointed out my mistake to the parents. And I think sometimes that's a good strategy too. I said, you know what I just did, I would actually not recommend to do, because she was interested in this other toy. She was holding it, looking at it, and I was trying to redirect her attention away and show her this other toy. So sometimes I think showing what pointing out my mistakes is a lot easier than pointing out to the parents like, oh, you're asking too many questions or you're doing that. I don't know. What do you think?
Oh, I think that is so smart. I absolutely am like, ooh, shouldn't have done that. And here's why. And so I remember one time where this kid, I think he was throwing beans at my face. He was doing something pretty naughty and I laughed. And that is like the kiss of death, right? Because the kid was like, oh, I'm funny. So then I think he threw more beans at me or something. But it was an opportunity to say to the parent, like, yeah, see that, how bad that went? Like, I would not recommend what I just did right there. And I think you bring up, another good point about, how do you get a parent to try this, right? So if you're a new clinician, I would just say like, maybe the parent practices, you don't even have to do it for your whole session the first time. Just say for 5 or 10 minutes, have the parent do an activity of their choosing. And that is so important. We, in, kind of the mainstream American, Euro-American like culture, which often dominates speech pathology because we are, 90% plus white, is play. But not all families might pick play as their routine. So pick a routine or an activity. It might be play, it might not be play, that the parent like does naturally and finds fun. And then just maybe just say, what do you think about every time you see your kid communicating, respond with what you would want them to say in that moment. That's the instruction. And then every time that parent does it, your job, new SLP, is to say, excellent, that was a great response. Start there and then just see. When I first coach parents, I do a lot of praising of what I want to happen and a lot of ignoring what I don't want to happen. And then as I build the relationship up, that's when I start to say, oh, that was a question, or like, oh, was he really interested in that horse, or was she like pretty interested in, the barn? But really at the beginning, when you're building that rapport, really focusing on what the parent is doing well, just so that they can build confidence.
I love that advice. And I feel like caregiver coaching is an art form because you have to read the child, you have to read the parent, you have to kind of offer your advice or demonstrate strategies or coach strategies. Kind of, you're as a clinician, you're looking at a lot of things and moving parts. And so it does take practice. And I think having clinicians kind of give themselves grace and through the process and keep trying.
I think that's totally true. I think the other big thing that I think I've sort of evolved in my thinking is about relationships, right? Like the best therapy is, it's not like a magic bullet strategy. Like it's really about the relationship you develop with the kid and the relationship you develop with the caregiver. And so it's that trusting relationship where you're co-creating goals, you're co-creating like, what's something, what's the activity we should do for today? Like you're jointly making the decisions and then you're executing that together and really seeing that caregiver as the expert in their child. And you might be the expert in some things, but that takes a kind of a paradigm shift, as SLPs sometimes want to come in as like, I'm the expert. And sometimes parents expect that, but really talking about how early intervention really is about a partnership between the providers and the caregivers. And that's what makes the outcomes so effective, I think, is really important.
Definitely. And I think kind of talking about that right away, because if you get into a rut of going and kind of the parents like, okay, great. And the parents might have a lot of therapists coming to the home and working with the child. So kind of being mindful of that too. But at the beginning, kind of establishing this is a together thing. We're all together. This is the time where we're all together with the child, trying to schedule that instead of, this is a time for me to be with your child and you not to be. So, I mean, it's interesting. It's a delicate balance, but I think starting that at the beginning is the best way.
No, I completely agree. And I think that, I've had SLPs say, they're like, but the kid does so much better when it's just me. And I'm like, well, yeah, you're novel. And if you brought a toy bag, that's cool. But also, yeah, if a kid can say all the words with the toy bag, all your special toys, but does not say all those things with their caregiver, like, is that what you want? Is that good speech therapy? Are those the outcomes you want? That's why I get like, when I see like dolphin assisted therapy or horse riding assisted therapy, I'm like, unless children are riding horses to and from school and in between classes, like I'm really interested in generalization, meaning what does the kid take from their sessions and
Mhm.
apply it to their real life? And I think that's the beauty of engaging caregivers, is because it's you're programming into your intervention generalization, because that caregiver is that child's, in many cases, primary communication partner. And I say caregiver because sometime it might be the parents, sometime it might be the nanny, sometime it might be the grandmother, right? It's about who is, and sometimes it might be the preschool teacher, right? Who is the primary communication partner with that child? And that's who, we focus on coaching in our studies.
Yeah, that's great. And speaking of coaching, I know you've done a lot um, about talking to families about ASD and the importance of that and how to approach that, when you're seeing signs of autism in a child you're working with.
Yes. And I will just say, I just noticed this, even though we went over these slides together. I don't know if everybody knows this, the movement about really the neurodiversity movement. And I just learned this from one of my collaborators, switching the term ASD to actually ASC, which is Autism Spectrum Conditions, rather than
Okay.
disorders. So I think that's something that listeners might, if they don't know about it, I think there is a movement change that autism as a deficit-based model is hopefully going to be a thing of the past, right? And a lot of the movement towards identity first language, so saying autistic toddlers versus toddlers with autism. People have different preferences. In my lab, we are more towards the identity first language, so saying autistic toddlers. And I say that because knowing that, where this movement is headed and influencing science as it should, is so important when we talk about families about autism. Some of them may or may not know about the movement or not, but how you have this conversation with parents, caregivers, will inevitably inform how they view their child and how they view autism. And so sorry, go ahead.
Oh, no. And I think that's really important. And yes, I think any SLP on Instagram who has kind of seen more the neurodiversity movement, see people talk about it, it is kind of a shift in the way that we talk about autism and autistic people. But I think that's really important. And I don't know if you know Carrie Ebert's seminars. She's an SLP who's has an autistic son, adult son. And she was just on a podcast that I listened to. And she said, the important thing is, are we viewing autism as a tragedy, or are we just viewing it as just is, like it just is? So and shifting away from saying like red flags for autism and just like signs of, I don't know what, and I know you're going to talk more about that.
No, I mean, I think that's exactly right. And that's exactly where I sort of have evolved since even writing that ASHA leader piece, right? Is that there aren't red flags anymore. It's just like early markers, early signs, early indicators that a child may have a different learning style and may have different learning needs and learning strengths. So I have an autistic niece, and it's interesting watching my kids process it. And so a funny story is my niece was like, what did she say? Emmy is my daughter. Emmy said something to the effect of like, hey, Mom, Savannah called me fat. And I was like, and she goes, is that the autism or am I fat? And I was like, I think that's the autism. And sometimes, Savannah might not realize that some of her words might be hurtful for you. And so all you can do is you can say, that hurt my feelings. And he goes, oh, I did. I was like, okay, cool. Yeah, that's it. And so it was this, and they are so tight, like they spent the whole weekend FaceTiming, but it's interesting. It's just like not a thing. It's like, oh, she can't do this. It's just like, she might not realize that Savannah is amazing. So is Emmy. And they're navigating this friendship like without autism being something that is wrong or something that's fixed or something that is, less than. It's just they have different styles, right? It's just Emmy is a massive extrovert. She talks way too much, right? Like way too much. And she's bossy. And so I would say that, Savannah's probably cueing her to be like, Emmy, like your voice is so loud. And then he's like, oh, okay, I'll lower it. Right. So in any friendship, any relationship, any dynamic, there, everybody, both sides of that, have to find a middle. And I think that's the difference. Is before it was always like, let's make it so all autistic individuals conform to kind of what we consider, neurotypical, air quotes, right? And so now it's more of a movement of just like, okay, how do we, within a diet or within a conversation or a relationship, how do the two people who are probably different on a lot of things, in addition to whether or not somebody does or does not have autism, whether or not someone is or is not autistic, see, still learning. And so I think it's moving towards that framework as opposed to this being this like deficits based, must fix, must do all things. And I'm still learning. Like I still make mistakes all the time. But I have collaborators who are teaching me. I have my sister who's teaching me how to be better. And it's a life. I think for me it will be a lifelong process of always trying to reflect on the biases and beliefs that I have from my own lived experience. And that applies to autism. It also applies to all things related to, systemic racism and all the other things that are affecting our society right now too.
Yeah. So what are some points when clinicians do notice signs of autism in a child? Like how should they approach the parent and talk about it?
Yeah, no, that is a question I think about all the time. I would say I always want to follow kind of the parents like lead and cue, just like I kind of follow the kid. And I kind of say it's like this dance you do, right? Where the goal is not to get the child in for a diagnostic. That's not the goal. The goal is for the parent to want to get a diagnostic. And that is a subtle difference, right? Like some parents will go through the motion, oh, my provider said I should do this, but I don't really think my kid is autistic. And that is not going to go well ever. And so you want to take your time really, working with the parent to kind of unpack some of the things you might be seeing, right? And so, for example, if a kiddo is, laying on his side and really looking at, the wheels of the train, or, laying on his back, and might be like looking at the things on the fan, asking caregivers, like, what do you think's going on there? Like, tell me more about when you might see these other things, right? And so really kind of these wonder statements, like, I wonder what's going on. And because ultimately what you want is the caregiver to say, like, I'm not sure, what do you think, right? You want, it's this like contingent help giving, right? You want to offer advice when a parent is asking for it versus unsolicited. And so you're kind of waiting, you're kind of creating a scenario or a situation in which the caregiver says, you know what, Meg, I don't know why he's doing that. Why do you think he's doing that? And that then becomes like, you know what, I'm not sure. Some autistic children often do, they often exhibit behaviors like this, right? And then it's a conversation of, what is autism? And I think what is autism is really changing. And how we talk about it being not from a deficits model, right? So I think then it's talking about learning differences and how we can support the environment, right? It's not just about changing the child. It's about how do we change our own behavior. So it's all the things. It's basically the goal is how do we make your kiddo communicate and do all the things that they want to do versus what we want to do, right? And so I think it's really thinking about then how do we get specialized intervention services that can help your kid be the kid he can be and wants to be versus what we think should be. Does that make sense?
Yeah. So it's more looking at how this child's access to their environment, life, school, friends, how we can help them better participate in their daily lives, kind of.
Yes. And some of it will be strategies we'll work on with the kid, and some of it will be strategies we work on with the environment, because it's not just about making the kid conform to the environment. It's also about saying, okay, environment, what's messed up about you?
Yeah.
So that you can better support the kid.
And putting accommodations in place and yeah, just kind of looking at the whole picture and how the child can be best supported. Yeah, I like that.
Absolutely. Yeah.
Great.
And I think the other thing that's really important to remember is that this conversation is hard and you're going to feel uncomfortable because it's hard to, it's just hard sometimes. And maybe I hope in 10 years from now, autism doesn't have the stigma it has, but it has a stigma. It does. And so often parents will react differently to it. And so I just want to label that for clinicians who, if they have their first conversation, it doesn't go well, it might not be anything that you did. It might just be the fact that this is hard and that you will get better with practice. And that there is, it's risky, right, to put yourself out there. And you know, I've said to families, I think your kid might be autistic. And then they go for an eval and he's not. And I'm like, I'm glad I'm wrong. And they're like, I'm glad you're wrong too. But it doesn't break the relationship or break the trust in the relationship the way that had I not said anything and they went and got a diagnostic for some other reason and then they were like, yo, Meg, did you think he's autistic? And I mean, they're like, yeah. And you didn't tell me, right? That is much more likely to affect your relationship with the caregiver, is not saying something than
Yeah.
saying something. And if you've already developed that relationship where you're saying, you know, like, I'm not really sure, here are some things I'm wondering, here are some things that say, yes, this looks like autism, here are some things that don't look like autism. And also that your kid can be autistic and all these other amazing, you know, autism is one part of your child. And just because your child is autistic does not mean that he or she is not any of these other things.
Yeah. And I think to your point, when you're with a parent and a parent has your advice and you're there as kind of an expert on communication and development, I think they kind of expect you to let them know if you think that you're seeing signs for autism. And it can be hard to say, especially as a new clinician or just in general. But I think you make some good points and you have some resources on your website, ei.northwestern.edu. So I think clinicians can go to your website, and I think you have a handout on talking to families about autism.
Yep. We're starting a brand new study too in September. It's for Illinois only, if you happen to be in Illinois, an Illinois EI provider, in which we are going to be doing autism evals for 1,200 children across the state of Illinois.
Wow.
Because the wait list is so long because of COVID. And so we are actually going to be teaching EI providers, developmental therapists, and speech pathologists to do a series of measures. And we're going to be comparing those measures, what the EI therapists think. So they're going to do the measures and then they're going to they're going to say, yes, they're going to give what we call clinical best estimate. So they're going to say, yes, I think the child has autism. No, I don't. And then we're going to compare that to experts, so who can usually diagnose autism, which is a clinical psychologist or a physician, with the ultimate goal of potentially creating a new diagnostic pathway, meaning that part of the reason there's a bottleneck is there's a shortage of providers. There's, I think, 23 developmental and behavioral pediatricians or what we call medical diagnostics in Illinois. Maybe there's less. It's around 20. But there's 4,000 EI-based SLPs. And so you can see if SLPs could be able to diagnose autism, that could really open up the bottleneck. And so that's the purpose of this grant, is to really test that. But also part of that is a series where it's all open source, because so many of the autism measures are very costly. And so these are all open source, easy to implement. And we're going to be developing a training about more strengths-based feedback, right? So how do you talk to families about autism, like in the diagnostic? And so we're going to be developing a set of tools and materials that are culturally responsive and strength-based. So more coming soon. Follow us on Instagram. We're going to try to post things as we develop them, but knowing that we also need to test them too. But that's a new grant we're starting related to this very topic.
Oh, great. And to continue on that topic, can you talk about some different methods of autism assessment?
Absolutely. So I would say if you are an EI provider in the wild and you're primarily like mostly doing therapy and you want to screen, like you kind of want to do like a level, what we call a level 2 screener. So level 1 screeners are for the general population, right? So they're the things that happen in general pediatricians' offices. The level 2 screeners are the ones that are kids at an increased likelihood. So they're kids that are most likely already enrolled in early intervention. So EI providers, I would say, I would be recommending a level 2 screener. And so there aren't that many level 2 screeners, but one that I really like is the screening tool for autism in toddlers and young children. I think it's called the STAT, and that's a great tool. And then I think the other one is the SORF, which is a systematic observation for red flags of autism, and that can be done. They haven't study. This is not. I have not researched these. These are other amazing researchers. And so that you can do from a home visit observation. So you can it's a checklist that you can complete out. And then there's a new one. I'm going to try to find it real quick. I think it's called the TASI, or I might be making that up. It's a new caregiver interview specifically for toddlers, like young toddlers. And so let me see if I can find it real quick. I think I can. Yes, it's called the Toddler ASD Symptom Inventory, and it's a 37-item questionnaire.
Okay.
And it was just published in 2017. And if anyone is listening and has paywall issues, just let me know and I can help you find it. And then another one, so that's an interview. Oh, and another really good, more level 2 checklist is called the Early Screening for ASD and Communication Disorders. That's Amy Weatherby's group. And that's I don't know if this is how you say it, ESA. It's ESAC, and that's 2021. SORF is Dow and all in 2020 wrote the paper on doing it from home observations, and then Coulter and everybody's 2021 for the Autism Symptom Inventory, which is the caregiver interview. And then the STAT is Wendy Stone, that's in person. But if you have to do it via if you're still doing telehealth because of COVID, Vanderbilt has a great measure, and all of the training materials are online. It's called the Tele ASD Peds, and it's the telemedicine-based autism evaluation tool for toddlers and young children. And so we did that when COVID happened. So I was serving on a medical diagnostic team when COVID hit. And as many of you know, kids age out, right? And it's even like, we think the wait list for kids under 3 are long. Well, after 3 is even longer. So there were a bunch of kids on our wait list that we knew, or on our diagnostic list, that we knew were just going to be, it was just going to take them forever now to get on another wait list. And so we pivoted really quickly and did the tele ASD Peds, I think with like 10 or 12 families. And I think that paper was published last year. And we evaluated what they thought of it. Like, because we were worried. It was like, can we develop relationships via Zoom? How are they going to feel about this? And, surprisingly, parents thought it, like, they did not, I mean, of course, they probably would have preferred in person, but they felt for the most part happy with it, and that they were able to. So what you do in that measure is that you coach the parent to like do a series of tasks, and then you score it. So you're kind of like, they have a headset on, like usually like, AirPods or something, or their wireless headphones. They set up their phone, and you're basically coaching them via Zoom to like, okay, like put something the kid likes in a jar, like you're giving them like little scenarios, and then you, the expert, air quotes, you, the SLP, are then scoring the measure via Zoom.
And how long does that take?
I think it's supposed to take like not that long, like maybe 20, probably 30 minutes to administer and score. I think, yeah.
That's not bad. I could definitely see tele-diagnostic assessments just kind of help to get more assessments done for these people that are on wait lists and can't, don't have a provider in their area.
Totally. Well, and also I read this very disturbing article that's like 89% of counties in the United States do not have an autism diagnostic place.
Mhm, mhm,
89% of counties, right? And so when we think about, rural families or counties that don't have the same resources, right? Like it don't have a lot of resources.
mhm,
Telemedicine, if we can do it well, I think really can open up opportunities that would not be there
mhm.
without it.
And then just can you talk about the importance of getting, because people might be thinking, okay, but why do they need the assessment? So what, especially in like different states, and um, what's the importance of having a diagnosis or an assessment?
I mean, I think it's really a family's choice. I will say that, the having a formal autism diagnosis often opens up more services for
Mhm,
you because of health insurance, right? Like with that special code, you can
mhm,
access more insurance, more services, than just EI. And so for some families, they might want more intervention early. And so that's a big one for families, is they become eligible for more services.
mhm, yeah. And same in, well, I lived in Canada, in Vancouver for 3.5 years. And same situation there, just a very, very large wait list for assessments. And the funding there is different based on the diagnosis. So families really wanted to have this diagnosis just to be able to pay for services. Yeah.
Exactly. Exactly.
Um, so I want to shift gears a bit and talk about incorporating data into our practice. I know it's interesting. I love that you're at Northwestern and doing research on with kids who have developmental delays, because when I was at Northwestern, all the research was done on like just language development, but there wasn't a lot that was done on kids who are having trouble or who are delayed. And I think it's really interesting, because I think that, the research that is out, there's kind of a paucity of research in helping kids who are delayed. So can you talk a bit about that?
Yeah, I mean, we did this paper. We looked at through all the ASHA journals and found that very few, most of the research is not what we call clinical practice research. And by clinical practice research, it means I can pick up the paper and from that, it tells me what to do, like right now in clinical
Mm-hmm.
practice. And, I want to be very clear. Basic science is so important to clinical practice. It's the foundation for all of it. But clinicians really they just really need more clinical practice research. I don't know why it's not happening more. I mean, I kind of do. It's hard and it's messy and it's not sexy,
Mm-hmm.
but it's so important. And I would say that we're really shifting my group. So right now, most of I do clinical practice research. Most of what I do is clinical trials, meaning I randomly assign people to either get an
Mm-hmm.
intervention or not get an intervention or get different versions of an intervention. And the person delivering the intervention is what we call a research SLP. And so she's a clinician, she's got her C's, but she's following a research protocol. And caregivers are getting their community-based early intervention in addition to the research protocol. And that's great and fine. And we're learning a lot. We have learned a lot about what is effective for families and kids, but we don't know how all these things will work in the wild, like in contexts in which we don't have the luxury and privilege of all of the things that Northwestern affords us. And so I would say that two things need to happen, I think, is focus. We as a field need to focus more on what we call implementation science, which is not does an intervention work, but how can we get the intervention to work in the real world and get people to use it. And so, we're writing a series of grants in which we're trying to study that, right? Where now the participant is not the parent, it's not the kid, it's the speech pathologist. We're trying to understand what are the barriers to SLPs in implementing evidence-based practice, because and not just SLPs, but also the system in which they work, right? It's not just that maybe the system is broken. Maybe we just don't know until we start to study those factors. And then develop intervention strategies to support the SLP to coach the parent. And so I would say that's something that's on my mind. I would say the other thing, you might be like, as a new clinician or a busy clinician or a whatever clinician, who might or may not get overwhelmed with data and research and think things to themselves like, I'm not good at math or whatever story you're telling yourself. The tip I would say I would suggest everyone to do would be to sign up for Google Scholar Alerts. It takes 1 second. You type in what you're interested in, and then every day Google will send to your email things that were published on that topic. Now, pro tip, don't make it super narrow because there's not that much stuff happening in pathology. So my Google Scholar Alerts are like autism, not intervention, not even intervention. Like, I want to know all the things about autism. I want to know like what like vitamin D and autism. Like, I want to know all the things about autism in case a parent asks me about the things that they might or may not see. And I don't read all of the art. I don't read all the studies. Like, never. I skim through them, and I'm like, okay, so two purposes of Google Scholars. One is to say, okay, what in general is happening in research related to autism? So I at least know it exists. And two, for things that really apply to me, I will read the whole article, and then I will be like, oh, I need to do this, or like, oh, that article is terrible and I don't need to do this. But it's I would say I'm maybe reading one article a week, and oftentimes I'm skimming that article. So I would just say, just like the advice I gave you about parents, try one small thing. I would say try one small thing with research. Just set up a Google Scholar Alert, just skim through them. It could be a replacement behavior. Set your timer for 15 minutes. You can only spend 15 minutes on Instagram, and then all the time you've got back, you can spend perusing a journal article. 5 minutes a week. Just start small and change the behavior. And then I think what will happen is you'll start to feel empowered and like, oh wow, I'm really glad I know all of these things. Then your self-efficacy increases because you know all the things that are happening in science. And it's kind of this cascading effect.
And I like that because it kind of goes beyond what's offered in the ASHA journals, right? Like you're kind of looking at, what's happening on this topic and
across journals.
Yeah. And that's what, just when I look at research, and I looked at a lot of research when I was developing my course last year, I just had to go to a lot of just language development research in general and looking at that. And then there are a few articles on the intervention strategies, like enhanced milieu teaching, and just like different, like toy talk and just different ones, but there's not like 100 of them. At least I didn't find.
No, there's not. No, there's not.
So I think that's a great advice. And can you just talk about a couple other keywords? You mentioned autism. Like, would you put in early intervention or no? Because that's not what a lot of people are putting in their articles.
So I have several Google Scholar Alerts.
Yeah.
So one of my Google Scholar Alerts is autism. Another Google Scholar that I have is early intervention, like quotes, early space intervention, end quote, because I want to know. Actually, my mom taught me that one. She sent me an article, and I was like, Mom, she was retired. And I was like, Mom, how'd you find that article? She's like, oh, my Google Scholar Alert. And I was like, what's your alert? She's like, oh, early intervention. I was like, oh, I'm going to add that one. Thanks, Mom. And so I've been getting, what I like about that is then it pulls up things from like allied health fields like OT and PT and special ed. So I like that Google Scholar Alert. And then I have one on hearing loss, deaf of hard of hearing, language impairment. I have one on parent-child interactions. I want to know all the things related to parent-child stuff.
I like that.
I have one on coaching. I like coaching too because I put coaching with other things because I'm not interested in like executive coaching. But I like coaching related to professional development. So like coaching of teachers, those principles and that science will apply to EI likely. So that's another one I really like.
Oh, great.
I would say the other thing that we've done is you kind of need an accountability person, right, in life to change your behavior. Like we know this, changing behavior is hard. So if you want to start to change your research-related behavior, I would say find one or two people and just commit, make it fun. Pair it with something you like, whether that is, in my case, anything to do with chickpeas. I love making hummus or like cookie dough, although people in my lab tell me my chickpea cookie dough tastes like chickpeas, but not cookie dough. But pair it with something that you like, whether that's wine or coffee or a walk or Peloton, whatever it is, like pair it, have a group of people, and just maybe once a month you all agree to read the same article and talk about it. It could be 10 minutes
Cool.
of talking and 50 minutes of fun, but
That's
pair
great.
it with something that
And then what do you suggest when people come across a paywall? So it's like $60 to access an article, or
yeah. So I would say you can, my first tip is you can email the author, because I get that all the time. They're like, I can't access your article. And it's rarely the case that it takes me more than 2 days to send the article. We get like complimentary proofs, and also like the unformatted, unedited, like, the one that's just the Word document, we can distribute often. And then if you're a scientist who happens to be listening to this, it's very easy to make the non-edited, the like formatted version available on like your own website. So all of my papers are on our website. They might be in the Word format, not the pretty journal format, but who cares? It's still the same comment. So I wish all researchers would do that, because paywalls are not cool.
that is great. And before, when I was prepping for this interview, I looked and I saw that you did have every full article listed, a link to it, of your research. I think everyone should do that, just to kind of.
I do too.
Because I don't think anyone likes the paywalls. So
no. And my really good friend and colleague Elizabeth Norton was telling me about this other site so now I actually will post my, like, while it's cooking in the journal review process on this open science site. And then once it gets accepted, I can update the version. But so there's different ways of doing it. Like, we'll always keep it on our website, so you don't have to go somewhere else. But now if you're interested in like what we're doing, but it's not yet been published, a lot of things are available now on these open science frameworks, which is great for clinicians who aren't associated with universities.
It's a great idea. Thank you. And can you just tell me a bit about some of the recent research that your lab has done? I know I saw something on the impact of COVID-19 on EI services. You did a paper on that. And can you talk about some?
Yes. So two papers that are not yet out, but should be coming out soon, anytime, is one of the one I was telling you about. Jordan Lee is a PhD student in my lab who looked at what is happening in real life. What amount of coaching is happening in real life. So that paper is coming out. I already told you those sad results. Another paper that was accepted that should be coming out soon is we looked at, so the broad autism phenotype is subclinical characteristics of autism, sometimes present in parents. And a long time ago, I had this dad and boy on my caseload, and this dad was like so good at some strategies and really not good at some other strategies I was trying to teach him. And I was like, I just feel like sometimes we're clicking, sometimes we're not. Like, sometimes I feel like I'm not like communicating something in a way that like he's understanding. Like, there was a mismatch. And then I came to Northwestern and got to work with Molly Losh, who is an expert in the broad autism phenotype. And then I was like, oh, that's what that is. And so this paper, we ended a grant that really looked at the extent to which the broad autism phenotype in parents influences their ability to learn and implement certain naturalistic intervention strategies, specifically responsive strategies, so responding to the child, and directive strategies, such as prompting and communication temptations. And so what we found is that it's easier for parents to learn responsive strategies than directive strategies. And it's, but that whether or not you were showing some characteristics of the broad autism phenotype did not matter, except if you, before intervention, before we coached you, you had high levels or low levels of a strategy. So what we found was that if you came before we even coached you, right from jump, you had really good strategy use. Actually, BAP positive parents did better than BAP negative parents. But if you came to us with really low levels, the BAP negative group did better than the BAP positive group. All that to say is that it matters. A few things matter in terms of a parent's ability to learn some or the ease with, I should say, the ease with which a parent can learn strategies. One is what strategies you're teaching them. Responsiveness strategies are easier than directive strategies. And two, where they start. Like, so if, where they start is a kind of a proxy for what they value and whether it aligns with their interests it really matters. And so I think that's a really important takeaway, is that, as much as we want to coach caregivers to do all the things we find effective, ultimately, our job is to work with them to find strategies that align with their values and preferences and priorities.
Oh, that's really interesting. And then the responsive strategies are responding to your child, and then the directive strategies, how do you categorize those?
So yeah, that's a great question. I speak so quickly. So so naturalistic developmental behavioral interventions, right? The NDBIs that we hear about in autism interventions have lots of strategies that go into them. Some of which we classify as responsive, so more child directed, more child focused. So it's following the child's lead, responding to communication, right? We're really following the kid. Mm-hmm. As directive strategies are more about setting up the environment to elicit communications, where you might hold up a choice and have the kid request, or the kid might grunt at you and you might say milk, right? Where you're doing a verbal prompt. Yeah. And so we found that caregivers had an easier time with those responsive strategies than the directive strategies.
Yeah, that makes sense. And it makes sense that going back to what you said first is for the newer clinicians, coaching on those responsive strategies first. Yeah,
exactly. Totally. And we are writing a few grants about that. Right? How do you teach providers to coach caregivers just to use responsiveness? Because then that's the easiest strategy. And then the other paper, there's two other papers that might be interesting to reviewer or to listeners, is that we looked at the impact of COVID on EI services in Illinois, and there were lots of sad things, right? Like kids, nothing shocking, right? Kids got less services, everything shut down. But what was interesting is that the amount of parent coaching and parent engagement in the sessions actually increased because, well, you have Zoom and it's really hard to engage a kid via Zoom. So I'm super interested. Yeah. So I'm super interested to know if this will stick, like, whether or not providers will continue. Like maybe they were like, oh yeah, I like engaging the caregivers, or when they go back in person, if they'll go back to more child interacting just with the child. I don't know. I'm interested to see what happens. I'm hoping that people will stay working with caregivers.
Yeah. I did a few early intervention sessions via Zoom, and I can say it took 10 times as much of my energy as working in the home, just because I felt like I needed to be constant. It was just, I got used to it at the end, but I never thought I would do teletherapy, but now it's part of my practice in not necessarily with EI, but overall. But I can see what you're saying, because you have to involve the caregiver when you're doing a teletherapy session in EI, because the child's just not going to sit in front with a headset on. So
absolutely.
Oh, that's great. That's an awesome observation. So is there anything else you want to share regarding the recent research? Or
just one other quick thing is that Bailey Sohn, who's a PhD student in my lab, published a paper on a measure called the NDBI-FI or FI. She did not make the measure. Brooke Ingersoll's group, Kyle Frost, I think the lead author on that paper. Basically, it's so hard we're so focused on child outcomes. And an important part of coaching is being able to measure parent progress using strategies. And so this is a really nice measure in which it's a rating scale, not for the kid, but on the parent. So you can kind of see how often a parent is doing all the strategies you want to hopefully teach them. And so we applied it to existing research videos, but I think an important next study would be to see the extent to which clinicians in the wild can use it. But that might be an interesting thing for anybody to check out if they're interested in not only coaching, but also measuring kind of parents change over time. Because when you coach parents, we also need to have parent or caregiver outcomes, and that's a really nice measure for those outcomes.
Oh, great. Thank you for mentioning that. And then can you let the listeners know kind of if they're in the Illinois area, or if they're not, even how they might be able to participate in some of your studies?
Yes, you can come to our website, ei.northwestern.edu, and there's links to all the studies. I will just say that we are actively recruiting nationally for 2 studies. One, tiny deaf and hard of hearing toddlers. So you're 12 to 18 months of age, and if you have a bilateral hearing loss, come find us.
Mm-hmm.
Or if you're a provider and you have those kids on your caseload. And then the other group is kids who are at increased likelihood of having developmental language disorder. So these are kids who have a language delay. They're around 28 to 30 months, so about 2.5. And they have difficulty with language. And so those are the 2 studies we are actively recruiting right now.
Great. Okay. And that's ei.northwestern.edu. And then can you tell listeners, I know we mentioned your Instagram before, but where they can find you on Instagram?
Yes, I am at ei.northwestern. So hopefully we'll see some more followers. We do Instagram updates each week. And so sometimes we're like 0 followers, 1 follower. So we love having more followers. So please follow us.
It's rough out there these days. You've got to do like a TikTok a day now, or I mean a reel a day or something.
Yeah, no, not happening for me.
I know. Well, thank you so much for your time. You have shared so much valuable information, and it's so exciting getting to hear from a researcher. And I know SLPs are going to love this interview. So thank you so much, Megan.
Thank you so much for having me. And if you're listening and you're going to be at ASHA, come find me. I'm always interested in saying hi to people that are in EI and want to learn more or already doing coaching.
Great. Well, thank you so much.